Hello, everybody. Thank you so very much for joining us for this webinar. I'm Dr. Joe Heyman, an obstetrician gynecologist from a small town in Massachusetts here in the USA, and I'm chair of the associate membership of the World Medical Association. We want to allow you folks to think about other issues besides the virus and to have some global interaction in spite of your local social distancing. I know that there may be some of you who may just be learning about the World Medical Association for the first time. So before we get started, I would like to introduce our incredible Secretary General, who has guided this organization since 2005, Dr. Ottmar Kloiber. Ottmar?
Hi, Joe. Thank you very much. And welcome to all of you to this webinar, which will be given by Ramin, the chair of our work group on the International Code of Medical Ethics. Joe asked me to say a few words about the WMA because we know that there are some people attending this seminar, this webinar, which are not that familiar with the World Medical Association. And to put this policy a little bit in the right place, what it means for WMA and what it means for our work. Now, just in brief, the World Medical Association was built in the post-wartime period in 1947. And since then, it is the global platform to work together on the development on medical ethics, on the medical deontology, and also to look into the social environment around medicine, what it means for us. And some of you have probably seen that we have done quite some work, not only on medical ethical questions, but also on social medical affairs, especially the social determinants of health. Aside from that, the World Medical Association does with its 113 national medical associations as what we call constituent members, we do a lot of work in the field of human rights and medicine, education for niche subjects, like for instance, prison health, that has been developed by some of our members, or other items like, for instance, multi-drug resistant tuberculosis, for which we have developed courses, and many other things we have been working on. Since the 40s, there has been a core package of important policies, which started actually in 1948 with the Declaration of Geneva, and then 1 year later in 1949 was complemented with the International Code of Medical Ethics. That code has been forgotten for a long time, I would say. It has not been really gotten the attention, and that was the reason why we started to rework on it. The World Medical Association is probably more known for other policies, like for instance, the Declaration of Helsinki, the ethics on medical research with human beings. But really, when it comes to the core of medical ethics, then certainly the Declaration of Geneva and the International Code of Medical Ethics are the core pieces to which we put most of our attention. And so I thought it was a very nice idea, Joe, to have Ramin invited to speak about our current work on the declaration, on the International Code of Medical Ethics. And that is a work which we do in a very broad way, trying to involve as many people, as many interested people, not only doctors, but also ethicists and other people who are interested in it, to be involved in this work, to bring us forward and to have ideas brought into the work on the International Code of Medical Ethics. So this seminar is not only for information, it is also to stimulate the discussion with our peers, with societies we work with, and very especially our associate members, from which we have received considerable input during the past years. So let me thank you for taking part in this webinar. Feel free to ask questions. Not all questions will be answered during this webinar, of course, and the development will go on, as Ramin will tell you later on. And you are all invited to bring input to this discussion and to the development of the International Code. Thank you, Joe, and back to you.
Thanks, Ottmar. Now, I would like to mention associate membership in the WMA. While the WMA is an organization of national medical associations, There's also the opportunity to be an individual member of the WMA if you're a physician or a medical student. The advantages of associate membership are your ability to individually introduce global policy for the WMA, to discuss and offer modifications to proposed WMA policy, and to join us in person at council meetings where you're given a voice and have the opportunity to meet brilliant, fascinating people from all over the world enjoying new cross-cultural friendships. To join us at a very inexpensive price, just go to the WMA website at wma.net and click on Join Us in the upper right. By the way, this program is being recorded, and thanks to Dr. Marion Mayman for coming up with the subject and our speaker. And one other detail, you will all be muted during the entire session. You may ask questions by typing them into the questions section you can see on the right side of your screen. And we'll try to get through as many questions as possible. Now, speaking of brilliant, fascinating people, you received Dr. Ramin Parsaparsi's resume with the second invitation for this conference. He's a wonderful guy who's had a tremendous positive effect on the ethical policy of the WMA by his leadership on the update of the Declaration of Helsinki, our global historic policy guiding the experience of human subjects in clinical trials. His influence in the latest version of our Physicians' Pledge, the Declaration of Geneva, and now his leadership on the proposed update of the International Code of Medical Ethics. He's a very practical, organized, specific, caring physician, and all of us at the WMA admire him greatly. It's my pleasure and privilege to introduce Dr. Ramin Parsaparsi. Ramin?
Yes, sir. Thank you very much for this very kind words, Joe. And at this point, I would also like to thank Dr. Ottmar Kloiber and Marianne Maman, and also you, Joe, for inviting me to hold this session here today, which is a really wonderful opportunity. This endeavor is really something we would like to do as transparent as possible and as inclusive as possible. That's why it is such a wonderful opportunity to do this today and to have also the input from the associate members, but not only from the associate members. I understand that a lot of other experts have joined us today, and I would like to welcome everyone. But most of all, I would also like to welcome my fellow workgroup members. A couple of them joined us today, and they will also serve as panelists later on during the questions and answer session. And I invite all of them to be an active part of this. I'm going to give a rather brief introduction to this whole topic, but I would also like to reserve a lot of time for discussion, for questions and answers, because what we really want to do is we would like to hear what you think about what we're doing, where we stand, about the proposed wordings we have. So I would like to invite later on all listeners to actively participate and all workgroup members to be ready to also answer questions and be part of the discussion. Thank you very much.
Ramin, excuse me for interrupting, but I just saw that apparently the draft of the international code was distributed by email under the handouts and was uploaded. So if attendees want to see that, they can see it that way. Sorry.
Excellent. No, absolutely. This is an important point, Joe, and I thank you for mentioning this. Actually, this draft that we have sent beforehand to those who have registered, it's the draft that the Medical Ethics Committee of the World Medical Association has sort of green lighted back in October when we last time met in Tbilisi in Georgia. And this is already a revised version of the ICOME. Of course, it's not the final version, it's just a draft which includes a couple of changes. During the last few weeks and months, we had further conference calls with the work group members, and we have discussed further changes which are not yet in that document. So please consider that this is a document from October last year. We didn't want to share any other more updated document because the Medical Ethics Committee of the WMA hasn't even seen it. We were supposed to meet, I think last week in Portugal. Unfortunately, due to the current circumstances, the meetings were canceled. So that's why we were also not able to share a more updated version of this draft. But what I can do later on when we get to it, I can just share a few more details and some of the wordings that we have discussed so far, and we can certainly discuss them here in this setting. That won't be a problem. Now, you know, Dr. Kloiber already mentioned some of these very core documents of the World Medical Association that probably most of you know. Most of all, of course, the Declaration of Geneva, the Physicians' Pledge. I guess almost all physicians know about this document, and it's indeed a WMA document. The Declaration of Helsinki, I think everyone who has been in clinical research must know this document, and it's probably the most prominent document of the World Medical Association. But there are other very important documents of the WMA that are also frequently cited, such as the Declaration of Tokyo, which provides guidelines for physicians concerning torture, or the Declaration of Lisbon, which deals with patient rights. Now, Dr. Kloiber rightly also mentioned the International Code of Medical Ethics as one of the core documents. But I mean, if I asked you now to raise your hand if you actually knew about this document before we scheduled the session or before we started this review process just last year, I would probably not see that many hands going up. And that's no surprise, because this document has not been widely used, not been widely cited, but I can assure you that this is going to change. And this is also one of our objectives, to not only revise this document, but also make it much more visible and much more used worldwide. Just a few words on the history of this document. It was in 1948 when actually the Declaration of Geneva was approved by the World Medical Association General Assembly, when the Council decided to appoint a study committee to develop the International Code of Medical Ethics. This was all still in light of a report on war crimes in medicine. And the study group, they worked on it for about a year, and then the General Assembly adopted it just a year later in 1948 at the Third General Assembly in London. Now, we all know that the Declaration of Geneva works really as a standalone document today. And this is unfortunately not really the case with the DOG, with the ICOME, because that really was based on the DOG, and it was also always kind of an appendix to the DOG, kind of a more comprehensive version of the DOG that explained more detail the principles of medical ethics that also were mentioned in the DOG. So it has always been presented in conjunction with the DOG. And because the DOG and the ICOME are so closely interlinked, please allow me to say just a few words on the Declaration of Geneva as well, because you will see later on this is very important for our revision process right now as well. The DOG was just adopted a year earlier than the ICOME in 1948. It was the second General Assembly of the World Medical Association, and we all know that today it's kind of conceived as a modern Hippocratic oath and used in many countries at universities where physicians, when entering the medical profession, are supposed to pledge this declaration. It is really considered as one of the core documents of medical ethics, and it is actually a document that also was developed in a time right after the World War II, facing the moral failure during those times. Now, the Declaration of Geneva has gone through a couple of revisions in 68, 83, 94, and most recently in 2017. Those were the major revisions. There were a few smaller editorial revisions, but 4 major revisions. And what we saw that what has not changed during all these revisions, that were the basic ethical principles. They have never changed. And what has also not changed is the overall character, the structure, the basic length of it. And those all didn't change significantly. Most importantly, there has never been a shift of paradigm during the revisions, and the few amendments, there were mostly clarifications only. During all these years, we also only have very few additional provisions added. Now, in 2017, when the WMA General Assembly adopted the most recent version, this was actually a version that has a rather more comprehensive revision and a few more changes than during the past few revisions. That's why I would like to quickly explain what has happened during the last revision process, because we will probably need to adapt the ICME according to what also has changed in the DOG. Most of all, we introduced a subtitle, which basically says what the DOG is, the physician's pledge. But then there were smaller changes. For example, in the DOG, it only called for students to respect their teachers, but not the other way around. While interestingly enough, the Hippocratic Oath always called for mutual respect. So we changed that and we added the reciprocal respect to the DOG. What we also did, we added the term well-being to health and well-being, because we thought that's rather comprehensive, and it kind of reflects how this term is used in most other international documents and also in other WMA documents. But what is really notable is the additions we made to the DOG. I put them here. Most importantly is probably the addition of the patient autonomy. Interestingly enough, this is one of the core principles in medical ethics, and it is used in many other documents also of the WMA, but it was not included in the DOG so far. So we thought it is due time to include it also in the DOG, and the new paragraph reads, "I will respect the autonomy and dignity of my patient." Then we added the obligation to share medical knowledge. The sentence reads, "I will share my medical knowledge for the benefit of the patient and the advancement of healthcare." But probably the addition that generated most attention also of the media and the wider public is our last edition. It's the obligation to take care of your own health and well-being. The new paragraph reads, "I will attend to my own health, well-being, and abilities in order to provide care of the highest standard." Now, we also thought this was high time to include this paragraph, and yes, it really generated the most attention. We didn't expect that beforehand, and it was really interesting that we only got very positive feedback on this edition, and actually we only got very positive feedback on the entire revision of the DOG. Now, all these three additions, they really need to also find its way into the ICOME. At least that's what the work group thought so far. But in the very end, when the DOG got accepted in 2017 at the GA in Chicago, the work group also recommended that the revision of the DOG should not be an end in itself. The work should continue, and it's important to improve its visibility and its usage. And also, and that's what I also mentioned, is that we need to address the issues that are not covered by the DOG so far, but important ethical principles that we, for example, also got through the international open consultation that we had. We got so many good inputs, so good suggestions, but they all could not really find its way into the DOG because of its succinct nature as a physician pledge. But the work group suggested that this would be, the right thing to include it in the International Code of Medical Ethics and to adapt also the international code with the most recent changes of the DOG. Now, as most of you probably know, the WMA has the policy to revise and review all its declarations, resolutions, all its policy paper every 10 years. And it was actually also time for the international code to be reviewed. And that's why the council decided to embark on a revision of the ICOME as well. Now, to make clear again what the difference between the DOG and the ICOME is, the DOG really is a pledge which outlines the basic ethical principles for physicians. It's very comprehensive, but still short enough to serve as a pledge. In contrast, the ICOME is much longer, it is much more comprehensive, it explains a little bit more in detail the ethical principles. It's really a foundation of ethical principles for the globalized world. And ideally, it should serve as a template for national codes. Now, as I said before, the ICOME is really a powerful document with great potential in its own right, but unfortunately it didn't achieve the same level of exposure or recognition as the Declaration of Geneva. And, this is also mostly due to the fact that the ICOME was always attached to the DOG. It was kind of a little bit in the shadow of the DOG. The ICOME was revised 3 times so far, in 68, 83, and most recently in 2006. So it was actually also high time to look into it if it has to be revised. And the WMA Council, they decided to have a work group to do the revision. And as you can see on the screen right now, these are the members of the work group. Now, you should know that usually the WMA Council only appoints a maximum of 5 to 6 countries, member organizations of the WMA, to do work on policy papers. Now, in this very specific case, an exception was made, and there is a smaller core group which NMAs are member of, representing really all the different continents worldwide. We have representation from Australia, from Brazil for South America, from Germany for Europe, Japan for Asia, South Africa for the African country, and the United States of America. But then there's also a little bit more enlarged work group as well, including Nigeria, the United Kingdom, Denmark, and Kuwait. And what we have done so far, we have always admitted any delegation from other countries to join us in the work group. We thought it is extremely important to be very transparent in our work. So we have very regular participants from China, from Sweden, from France, and from CPME, which is the Standing Committee of European Doctors. And I really have to say, it's wonderful how some of these observers are extremely active and actually are present in all our meetings and in all our phone and video conferences. It's really wonderful. So I'm very pleased. And even though we have a rather big group, we work quite efficiently. So this works pretty well. And I have to say, although it is sometimes challenging to have all the different views of the different kind of backgrounds of our workgroup members, it is extremely rewarding to have this experience. So we are all actually looking forward to the continuous work. The work group in the very beginning decided to, explore the ISOME very thoughtfully and give it ample time to update it. So that we didn't want to rush into it because it's a rather significant document, and we thought there should be a lot of work to go in. First of all, we wanted to ensure the compatibility with the newly revised DOG, but at the same time with the full spectrum of WMA policy papers. And this is a great challenge because, as you might know, there are a lot of WMA policy papers, and it is rather challenging to decide which of the principles, which of the policies should find its way into the ISOME and which might not. What definitely will go in, at least that's what the work group so far decided, is the adaptation in terms of what has changed in DOG. That's patient autonomy, the sharing of knowledge, mutual respect between teachers, students of medicine, and physician well-being. And if you look at that document that we have shared beforehand, you will probably see that these principles have already found its way into the document. Then we will also take the opportunity to explain some of the concepts of the DOG a little bit in further detail, like good medical practice or confidentiality. Already during our workgroup meetings, both during the revision process of the DOG, but also the revision process now, we found that some of these concepts are understood very differently in different parts of the world. So we would like to really have a wording that suits all of us. And I mentioned that before, we would also like to include some of the ideas that were submitted as part of the DOG public consultation, which was really a great feedback we got from the international expert community, but they could not be incorporated due to the nature of the physician pledge. Now, what has changed so far? I mentioned some of the changes that were very obvious, namely the adaptation in terms of what happened in the DOG. You will find that in the document already. But what we have also done is some editorial and structural changes. We introduced a preamble. What we have also done is to develop a new structure with additional headings. We thought that the content would flow a little bit better. It would be a more logical flow. And we added, and we introduced a new, more modern language. Before, if you know the ISOME, how it was the original one, every sentence started with a physician shall. We thought this is a little bit outdated. We thought a more modern language would be suitable, and we changed the language to kind of meet the standard and the language that is used in other documents, such as the Declaration of Helsinki, for example, or other documents of the WMA. We also introduced a more gender-inclusive language and smaller details. For example, we refrained from using the term colleague because at the time when the declaration, when the ISOME was approved the first time, when referring to a colleague, it was always meant a physician colleague. But now in the modern healthcare setting, of course, a colleague are all members of the healthcare community. all healthcare professionals. So we refrain from using just colleague, but we refer to physician colleagues or to other healthcare professionals as well. In terms of content, we have also discussed a couple of possible changes. And this is actually what I referred to in the beginning, that a lot has actually been discussed since last fall, but this has not yet been seen by the ethics committee. So I would like to give you just a little flavor of what we have discussed so far. And of course, I would like to hear your comments on this as well, to see if we are on the right track, if you could agree with what we are envisioning for the changes regarding this topic. First of all, informed consent. In the work group, but also during the 2 regional meetings that we had so far, and I will refer to that later on again, during all these sessions, there has been a great deal of support for including more content on informed consent, specifically as an aspect of patient autonomy. Now, doing this, the work group also, of course, considers what is in the other WMA documents, such as the DOH or the Declaration of Lisbon on Patient Rights. And we don't have any final wording here. I'm also grateful to the Danish Medical Association that has sent us suggested wording. So there is no final wording here that I can share with you, but I can assure you regarding this topic, of course, there won't be any major surprises because we have very good other documents where this has been dealt with in length, such as the DOH, and we will surely, base our wording on those documents. In terms of patient confidentiality, we have also put new wording in the document. You might have seen that in the document we shared. There is a small change in that already, and I'm happy to read that out for you so that you are familiar with where we might be heading. What we have deleted is the reference to the higher ranking legally protected interest, and the wording reads right now, the physician must respect a patient's right to confidentiality even after a patient has died. It is ethical to disclose confidential information when the patient consents to it, or when significant harm can only be avoided by disclosing information that should otherwise be kept confidential. Now, this is a wording that is currently being discussed, and again, I apologize that I don't put that on the screen because this is just internal discussion right now in the work group, and I didn't feel at liberty to share it completely, but I think just reading it out once and just to hear your comments, we can repeat that later on if you would like. We will still have to discuss, we will still need to fine tune the wording a little bit, maybe change the word significant harm to substantial harm, but this is still under discussion. And actually, everything I mentioned here, which says also on the slide, this is subject to change because nothing of this has been approved either by the Ethics Committee or the WMA Council. Now let's get to the next topic, and you might agree with me that this is probably one of the most controversial ones, conscientious objection. It's a rather tricky topic, and the work group has already discussed this a couple of times, starting from if we should have any wording on this in the ISO-ME, and if, then what kind of wording? I think so far what I got from the work group is that we need some sort of a wording, and there are 2 different options that are being discussed right now, or maybe even a mix of those options. I'm going to quickly read it out to you, and then we can discuss later on again what you think if there should be wording on this in the ISO-ME. Now, what we have discussed so far is, I read it out. Physicians have a right to conscientious objection in exceptional cases not related to health or motivated by discriminatory intentions. In all cases, they must ensure the continuity of medical care by qualified colleague. Now, this is one version. There has also been an alternative proposal which reads, physicians do not have the right to conscientious objection unless the continuity of medical care by a qualified colleague is ensured. Well, another option would be to combine these two, and that was also actually suggested in the work group, and we will need to think of ways how to combine this and what the most appropriate wording for the ICOME is. This is probably the most tricky part of the revision process, and we won't rush into any wording. We really want that everyone feels comfortable in the end with this. And again, I am eager to hear what you think about this topic, and we can discuss this. Then the work group discussed about the physician well-being. This is actually something that we have already included in the most recent draft. You might have seen it. But getting the feedback from the regional conferences, which suggested that it might make sense to expand on the already added wording, we might need to discuss if we want additional wording there, probably specifically referring to situations where violence against healthcare professionals impedes physicians' obligation to provide care of the highest standard. So this is something we might also look into it. No wording has been developed so far, but this is something we might need to discuss. Same thing with the topic of advertising and social media. The work group plans to include a specific clause focused on medical ethics issues related to these topics, especially in ways in which social media can potentially play a role in breaching medical ethics. So also no wording has been proposed so far, but we will also use some of our work group members who have already worked, put significant work on this, and we will tease their brains, of course, for the development of appropriate wording. In terms of telemedicine, the work group thought with the rise of telemedicine that it's important to understand which ethical principles are potentially threatened by this form of communication. And we thought it also makes sense to include a clause about the importance of preserving the sanctity of the physician-patient relationship when technology is concerned. So this is something we will also work on. No specific wording has been developed so far. In terms of equity in healthcare and health-related justice, this was actually a no-brainer. This was actually pretty straightforward. We have already included some extended wording in the document that you have. I read that out to you again. The physician must practice medicine fairly and justly and provide care without unfair discrimination or bias on the basis of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor. So we kind of revised the original wording and included the terms fairly and justly, but still the work group thought we might need some additional wording on this, and we have already drafted an additional paragraph, which again has not yet been finally discussed. That's why I can only read it out to you. Physicians must support fair and equitable provision of healthcare. This includes addressing persistent inequities in care, as well as violations of the rights of patients in healthcare professionals and healthcare professionals. So this is a wording that we are currently discussing, and it might well be that something along this wording will be added to the document. Now, all of this really depends on where we further go with this document. You know, also there are additional topics that could find its way into the ICME, but all these potential changes really depend on what the overall character of the code is supposed to be in future. And this is also something we discussed from the very first session we had with the work group. Should this be a standalone document or rather a supplement to the DOG, which means like more or less what we had before? So this is a really important question, and we spent some lengthy time discussing this. And because that makes also difference in terms of other additional topics we could include in the ICME. If you look into the Declaration of Geneva and the current ICME, we see that in terms of the relationships, the responsibilities and interactions of physicians and other players, what has been included so far. It's mostly the interaction between physician and patient, and physician and the responsibilities and interaction with the society. We also recently added with physicians themselves, for example, in terms of physician well-being. That's the responsibility that the physician has to him or herself. Now, the question really is, do we have to consider for the ICME also the responsibilities and interaction of physicians with the profession itself, or even with the organized medicine in all the associations we might be member in, or the societies and all that? So this is also a question we have been discussing. We have been considering for our future work, and that might open up a lot of additional topics that could potentially find its way into the code. You know, in terms of collaboration with other health professions, duties towards the environment and animals, responsibilities of physicians within organized medicine, and responsibility of physicians to the healthcare system as a whole. In terms of duties towards the environment and animals, you have probably seen there are already two new paragraphs in the revised draft that we had distributed. At this point, the work group has already decided to take out the reference to animals. We thought that might go beyond the scope of a document such as the International Code of Medical Ethics, but we will keep the reference to environment. In terms of responsibilities of physicians with organized medicine, within organized medicine, we thought it might make sense to include a wording here. We have discussed several ways how to find the appropriate wording. I think there are also suggested wordings in the document you have seen. We have reworded it slightly, and I would like to read it out to you so that you know what we are currently discussing. The first paragraph would read, as members of the medical profession, physicians shall protect and promote the ethical principles of the code. They shall use their advocacy powers to help prevent any national or international ethical, legal, or regulatory requirement to undermine any of the duties set forth in this document. So this would be one of the sentences which kind of describes the duty of a physician within the organizations of medical profession. Another one would be, I read it out, as members of the organizations of the medical profession, it's the task of physicians to support fellow members in upholding the responsibilities set out in this code and to take measures to protect them from undue influence. Now, these again are just proposed wording. Nothing has been decided so far, and I'm eager to hear what you think if a reference to the duties of physicians in organizations should also be mentioned in the ISO-ME. Now, one thing that we have always said is that the DOG and the ISO-ME, they should remain, the tone of both documents should always remain completely distinct, meaning one is really a pledge and the other one is more a comprehensive document with the core principles in medical ethics. But at the same time, any contradiction with the DOG should be avoided. And most importantly, the code should be applicable to different cultures and political systems. That's why we have this truly international work group. And I already mentioned it might be challenging at times, but it's also extremely rewarding and interesting to see how some of these principles are understood in different parts of the world. This is our timeline and work plan. You see, we gave it quite some time in the beginning because we really wanted to have a comprehensive revision process where we include all the different opinions from all around the world. We started in 2019 with a list of priorities and an internal consultation. Now in 2020, we we're planning on having a couple of international and regional expert conferences. We already started early this year with a conference with a regional meeting in Kuwait, which was an exceptional, good meeting. It was very well organized. We had more than 400 participants with many physicians of the entire region participating. We got great input there, and I would like to thank again the Kuwait Medical Association for hosting us in Kuwait City. It was an exceptional conference and we have made great experiences there. Then we also had a conference in for the South American region in Sao Paulo in Brazil, which was also perfectly organized. We had a good outcome and many participants from the Latin American continent, but also from Portugal and Spain. And we got really helpful feedback for our work. Now, we were planning on having also another international conference at the meeting of the International Association of Bioethics later in June this year. We had envisioned a satellite conference. The meeting was supposed to take place in Philadelphia in the United States, and we're really sad that this had to be canceled for obvious reasons, but unfortunately this is not going to happen. We had already great speakers lined up, but I guess this was not something we could envision beforehand. We have also further meetings planned, which probably not going to happen this year. For September, we were invited for a meeting for the Asian region in Thailand, and another meeting was scheduled by the end of the year in Africa for the African region. Now, and those other conferences might not take place. We will have to see, but hopefully, if it can't be done this year, we will hopefully do it next year. And we hope that in the end, almost everyone on each continent would have access to any of those regional conferences and to be part of the entire process. But at the same time, even though we might be a little bit challenged with the regional conferences, we still are going to have a public consultation. Initially, it was scheduled for May 2021, May or June. This has been proven a very helpful way to solicit comments from all experts around the world during the DOG and DOH revision processes. We hope to do that in 2021 again. Probably it needs to be rescheduled a little bit because it might make sense to first have more regional conferences before we have that public consultation. But our objective still is to have the document ready for 2022 for WMA member organizations to discuss it, and finally get the approval of the Council and have the adoption of the WMA General Assembly in October 2022. Now, this is our timeline work plan, and let me just say in the very beginning, in the very end, why we really think this is such an important document, especially at this point in time, because we can see that physicians face unprecedented challenges everywhere in the world, including changing political, legal, and market forces. And we can see that the medical profession becomes more and more dynamic, more and more globalized, which means at the same time it is more important to speak with the same ethical language. And it is even more important to reaffirm the fundamental and universal principles of medical ethics. We truly think that the Declaration of Geneva and then a revised International Code of Medical Ethics can play a major role in strengthening professional identity and adherence to professional ethics. And we hope not only to revise this document, but also make it much more visible and much more used worldwide. And we trust we will have your help and support by doing this. Now, this would be my introduction. I hope this was helpful to you to start the discussion process. I understand this webinar is scheduled for around 90 minutes, so we would have another 40 minutes now for discussion if you like to. And I'll be available, of course, for any questions you might have. But again, I would also like to refer to my fellow workgroup members. This is really a group endeavor, and I hope my colleagues from the workgroup will also join me in answering your questions. Thank you very much.
Thanks so much, Ramin. That was great. We already have 5 questions, and why don't I just read them off, and you can decide how you want to handle answering them. The first one is from Dr. Moroker from South Africa. He asks, in terms of sharing knowledge, what kind of protection can the WMA extend to doctors who may want to share knowledge in general, but and beyond their borders, but they're persecuted by their local government?
Okay. Yeah, it might make sense to go question by question, right? Or would you like to read them out first all and then?
No, I thought we would go question by question because
Okay.
people keep adding them.
Yeah. Well, right. We hope to include a wording on sharing knowledge in terms of the protection of individual doctors that might be persecuted. I guess this is something, I don't know, we have to see if this is something which should go into the document. But I understand we have also other WMA policy on this. I invite all the workgroup members, if they want to comment on this, or maybe even our WMA Secretary General, Ottmar Kloiber, if he would like to comment on that.
If I may, Joe?
Yes, of course.
Yeah, well, first of all, we have no fleet and we have no military power to enforce anything in any country of this world. So what counts in the first place is the quality of the paper that we present and the convincing power of that paper we present. But what we certainly have learned and what we are currently looking into is how does that work in more authoritative regimes? For the COVID-19 planning, it's very clear, and I think even the leaders in China have understood that suppressing this knowledge is actually not very helpful. It brings about a lot of damage. It has produced a significant damage to the industry in China not to be able to react earlier if they would have done that, and much more clear. It probably has also limited the response in other countries. That's something that is also being raised and being questioned right now, and I think that's a question that really has to be answered. So I think we have to look more into the mechanisms of what it means to share medical knowledge and how it helps to develop health, to protect health, and also to protect the economy as we see right now. Will we ever have a direct power to intervene? Certainly not. And certainly we are not the police, and probably we as physicians don't want to be the police. So it is something that we really have to bring forward with our arguments, with our papers, with our ideas about what it means. And that is the best we can do on this right now.
Thanks, Atmar. The next question is from Dr. Comrade. What is the distinction between the International Code and the WMA Declaration, such as the WMA Declaration on Euthanasia and Physician-Assisted Suicide? He says, I assume the latter is grounded in the principles of the former as applied to a specific medical practice or law. So if a practice violates a declaration, such as this one, why can't I see the rest of what he said? Such as this one, does it also violate the international code?
Well, I think in principle, I think I mentioned that during my presentation. What we are trying to do during this revision process is to make sure that none of there won't be any contradiction with any of the WMA policy papers. That we really try to consider the entire WMA policy apparatus and have no contradictions there. Of course, we can't go into the same detail as in other documents. And also, these are the core ethical principles. So we can't really cover everything. You know, I mentioned the topic of animals, for example. This is an extremely important topic, but it might go beyond the scope of the ICOME. Again, we are still discussing, for example, the topic of conscientious objection, if this is something we can term as a right or not a right. And I guess this goes somehow into the same direction. We have to see in what form it needs to be in the ICOME or not. And what we definitely make sure is that there is no contradiction at all.
And then the next, thank you, Ramin. And the next question is from Dr. Dye, Ames Dye. In light of the current pandemic, would you consider an article on physicians' duties and societal reciprocal responsibilities during crises?
Yes, thank you. Of course, this is something extremely interesting. You know, this is something we haven't discussed in the work group yet. But if you look at the ICOME, the new preamble, which also reflects some of the other documents such as the DOH, you always have to read the document as a whole. And if you really do that, I think that it also covers the entire our core principles, what we need. And if in addition to that, we think there should be something in terms of healthcare emergencies or pandemic situation. We haven't discussed that so far, or if it's already covered by the entire document.
Atmar?
Yeah, well, the WMA has specific policy on disasters, pandemics, and also wartime, which relate to the question of medical ethics during wartime, during pandemics. Basically saying, well, the fundamental basic medical ethics is valid during those times as well. But it's quite interesting to reflect now after the COVID crisis is over, whether we have to indeed connect those documents better and to make clear that there is also ongoing policy or additional policy and vice versa from the additional policy to say reflect better on the basic documents that we have, the Declaration of Geneva and the Declaration and the International Code of Medical Ethics, and also the Declaration of Helsinki, by the way, when it comes, for instance, to research. during pandemics and pandemic research there. So there is already a canon of policy dealing with those items, but certainly what we will do is after this, we will look into the interconnection and the interplay between those documents a little bit closer. I think that is what we have to do when this pandemic is over. By the way, if we would have followed all the policy which we have in this document on pandemic and disaster preparedness, this world would be in a better shape right now. I think we still have to do a lot of work with this ideas and policy which we have written, but obviously we're not capable enough of doing advocacy and work with it. Thank you.
The next question is related. It's from Mohammed Namazi. It says, in the current context of the COVID-19 pandemic, some ethical issues have arisen. The lack of PPE in certain countries has given rise to physicians not wanting to expose themselves without adequate protection. This is a real dilemma. Many physicians have succumbed to the infection. What would be the stand of the WMA from the ethical point of view? This situation may arise again in other situations in the future as well.
Thank you. And of course, this is an interesting question. Thank you for that. You know, I mentioned that we have added a wording on physician well-being, how physicians have to take care of their own health in order to provide healthcare of the highest standard. So there is already a wording in there. As I also mentioned, we still need to discuss if this needs to be expanded. But I guess this is rather a general question to the WMA, how this is going to be dealt with. This is not necessarily only a question for the ICME revision process.
And Dr. Gillen, did you want to add something?
Yes, from the point of view of the British Medical Association, we were quite keen in our advice about ethics in the current pandemic to point out that there's always a tension, and always has been a tension, between medicine's concern for the individual patient and medicine's concern for populations, for groups. And that in fact, if it becomes an extremely severe pandemic, the shift in the balance between those two concerns may have to move towards the public health approach of a concern for the population as a whole, and slightly away from the basic concern for individuals. So I thought I'd just add to the discussion there. People may not agree, of course.
Thank you. Next from Dr. John Schnadel. The first paragraph in general principles includes the line, the physician also has a responsibility to contribute to the health of other patients and society as a whole. This sentence does not make much sense. There is no limit to the number of whereabouts of other patients, and it is difficult to make physicians responsible for patients if they're not directly involved. What does health of society mean?
Thank you. Also an interesting question, and thank you, Dr. Schneider. It's always good to have you join us. Thank you for being part of this. But I don't want to be the only one answering here. We have also our ethics advisor, Urban Wiesing, here, if he wants to respond to that, or any other one of the work group. Please join in. Oh, Urban, great, yeah. Urban, I think you need to unmute yourself. We can't hear you.
Mute me.
We hear you now.
Now you're.
Okay, you hear me?
We can
Okay,
hear you.
fine.
Yes.
I think that's a good question, and indeed we have to discuss it because there is a tension always between the right of the individual and the outcome for a society. And usually a professional is obliged to the individual. And as the result of that, usually the level of health in a society is growing up. And I think that's what we have to make clear. The first obligation is the individual, not the society. But if we do that, good. usually the level of health in a society raises. So I would say it is obliged to the physician, to the individual patient, and therefore to the health of the society. We have to discuss that.
Very good. The next question is it possible to organize meetings or webinars dedicated to specific issues like autonomy, etc.? That comes from Dr. Zurkowski. Let me just say that just in general, if somebody has a great topic for a webinar, we'd be very happy to pursue that. As far as individual issues having to do with ethics, I would leave that to Ramin and his work group.
Thank you. I mean, what we usually do when we hold those regional conferences, we kind of highlight certain topics during those conferences. We don't discuss the entire International Code of Medical Ethics. So we chose some of the topics and then we discuss them. So there are focused sessions that deal with just some of these issues. And that's what we did also in Kuwait and Sao Paulo, and it proved to be extremely rewarding. If we can have these kind of discussions in form of additional webinars, that's really up to WMA and the associate members if they wanted to have additional ones, but I guess it could be extremely helpful.
Otmar?
Yeah, just agree. Please, if there are questions, like for instance, the question about physician autonomy, I think that is something which we can organize. It's a topic that is very close to the heart of the World Medical Association, and I think with the members and the associate members, we have an excellent group to discuss and also to work on this issue. So very happy to receive ideas, and we will try our best to organize something. But we also would like to invite the associate membership to provide themselves, because I know we have a lot of very knowledgeable physicians and advisors in our membership, in our associate membership, and please feel free also to make proposals to Joe and Marianne about webinars. I think that's a very nice tool to really deliver something to our membership, not only the associate members, but also the constituent members. Thank you.
Thank you. Fred White asks, the code makes no specific reference to affirmative or deliberate acts to end life, other than to permit the natural process of dying. Although the WMA Declaration on Euthanasia and Physician-Assisted Suicide and the WMA Resolution on Prohibition of Physician Participation in Capital Punishment specifically declare opposition to such practices, should the code do so as well?
Well, thank you. Another most interesting question, and I agree, this is a very good question. You know, I also mentioned already in terms of consensus objections, so far this topic was not included. And we're currently discussing if we should find some sort of a wording which should go into it, not objecting any of the WMA policy. Same thing with this topic. So far, it's not included. I don't know. We haven't discussed it yet. If we think it should be, but we certainly have it on our agenda, and we'll have to see if this is something we need to include.
Dr. Andy Gurman asks you to comment on the portion of the code which deals with treating family members. We have been discussing this amongst the associate members. The code currently states that it's unethical to treat family members. However, there are situations where this may be preferable. The code stems from the time when doctors were all generalists. In today's world, many of us are specialists, and the nearest specialists other than ourselves may be far away. He gives the example from his own family. For 25 years, he was the only hand surgeon within a 100-mile radius of his home. When his mother-in-law needed a very routine hand surgery procedure, which would have been preferable, would have been ethical or preferable to ask her to travel 100 miles over a mountain range to receive care. I and many other associate members would advocate softening or revision of the code in this regard. And I would just add to that, Ramin, that in Massachusetts, our governor during the COVID crisis has the Board of Registration in Medicine here in Massachusetts has rescinded the restriction against treating family members just for during the COVID crisis.
Thank you very much. I take it this is kind of more a suggestion than a question. So I'll take that on our list, unless someone from the work group would like to answer immediately his or her thoughts, but so far I just take it on the list of topics still to be discussed.
Okay. Then Dr. Anne Maria Arriagada. If I understood well, the new international code would maintain what refers to protection of environment, but not mention animal protection. How can we stand for the environment, not mentioning radical changes in the way we deal with animals?
Yes, thank you very much. As you can see, we initially had a reference to both topics in the code. Then the work group so far, this is not final, so far discussed and decided to leave the reference to environment in it, with animals not, because that might go beyond the scope. And there is actually a policy from WMA on this. But I see Ottmar would like to add on this as well.
Yes, go ahead, Ottmar.
Thank you, Joe. First of all, we have a specific policy on the use of animals in research, and that is something that is very touchy, very controversial, but certainly we don't want to import this conflict into the declaration of the International Code of Medical Ethics, because it's for most of the physicians, it's a very marginal problem. It's not in the center, and as I said, there is policy on that. Second, what I think is when we talk about the environment, we are talking about all the living structures in our environment which are to be protected. So we are talking about this variety of species that there, the responsible use of the environment, and that is the living structures which we have around us, all included. There is no limitation to plants or something like that. So when we care for the environment, we care for our habitat as a whole, and that includes, of course, all living structures in there. With respect to the fact that we eat some animals, that we use some animals, whether that is in medicine or in other purposes, for instance, for sports, when doing horse riding. But I think for the general code, we have to keep it on a very abstract level, and with the respect for the environment, I see this covered.
Thanks a lot. Dr. Catherine Ferrier says she's very concerned about the possible formulation about conscientious objection, stating that there is no right except. This would contradict the duty to practice with integrity. The problem seems to her to be the definition of what medical care is. For example, in Canada, euthanasia has been declared by the government to be medical care, obliging those of us who maintain that it is not to object conscientiously. Please make a clear statement in favor of conscience and align it with the duty to act with integrity against social or legal trends seeking to change what medicine is without consulting the medical profession.
Thank you very much. I understand this is actually a proposal or a recommendation to the work group and not a question, right?
Yeah, I think so.
Okay, thank
We
you.
certainly spent a lot of time on the other statements on euthanasia, so you know, I don't know how much you want to address this, but yes. The next question is from Dr. Agarwal. He asks whether we have immunity from liability during COVID for treating COVID patients in any other country besides the USA. I guess we should tell Dr. Agarwal that even in the USA, it's limited liability and it's on a state-by-state basis. And Atmar, did you want to add something?
Yes, the legal situation is very different from country to country. We have looked into this in other contexts, for instance, in the context of sports medicine or in the context of humanitarian assistance when doctors go cross-border and work in other countries. Some countries have solved these problems by either having mutual recognitions for cross-border services. That's the case, for instance, in Europe and some of the regional associations of states in this world. However, or second, by good Samaritan laws, which give then a waiver for liability. But the general answer is no. You first have to see whether such a waiver of liability is given for you in that country, and it still may be differentiated from what the waiver of liability is good for. When you go cross-border and there is no acceptance of your mutual acceptance of your license, consider that you are not a physician, and you of course have to help as a normal citizen or as a normal person in a situation of need and emergency. And I am not aware, to make that a little bit easier, I'm not aware that then people have been blamed for that. So I think that that is a very difficult and tricky situation, but unfortunately, it's not perfectly regulated.
The next question is from Dr. Sundaramurthy Annamalai. I hope I said that right. Asking whether medical ethics is the same in developing and developed countries, and what is the role of cultural and religious factors affecting medical ethics? Have we lost Ramin?
No. I'm sorry.
Okay.
I just had to mute myself. This is the challenge from working not from an office. There's a lot of construction work going on in this place here. So I had to mute myself for a few minutes. I'm sorry about that. A very good question. I mentioned before, this is the both rewarding and challenging thing during this revision process to kind of find the right and still appropriate wording for each of these issues. We can tell that there are very different points of views, especially when it comes to the controversial issues, and certainly cultural and religious backgrounds do make a difference, and we have to find a way to accommodate that. We are still in the process of it. What's really important is to hear all the different points of view. That's why we have this international work group, and that's why we have given us really ample time to deal with all of this. I see Urban has also raised his hand. Maybe he wanted to add to that.
Yes, two remarks on that. First of all, it is interesting that even in a multicultural society or all over the world, there are some principles valid for all physicians, and they are not controversial. Yes, a physician shall help. Well, could you think of anything else? No, that's written in the Hippocratic Oath. It is several thousand years old. That's still valid. So even in a different, culturally different world, we can recognize some certain principles valid for them all. And I have to remind you that one of the starting points of the revision process of the International Code of Medical Ethics was the situation we're living in a globalized world. We are traveling around the world, and think of the situation: you broke your leg in any part of the world, and can you expect, regardless where you are, certain principles valid for every physician everywhere in the world? So you can build a certain trust that, okay, regardless what happens, this physician will help me, he's confidential, and so on and so on. So yes, we are living in a multicultural world, but one of the tasks of this code is to see what are the core principles and which principles are valid everywhere in the world.
Thank you. From Dr. Chieko Kurihara, in the pandemic situation, there's a recommendation to remove artificial respirators from a patient in order to provide to another patient with a better prognosis. Is this acceptable from the view of the Declaration of Geneva or the International Code?
Thank you.
Go
Very
ahead.
timely question. I think Ottmar wanted to respond.
Yes, go ahead, Ottmar.
Yes, thank you. We have, as I said, we have a specific document for the medical ethics in such situations, which explains how these ideas, general ideas of medical ethics, have to be applied. And here it comes to the question of triage, pre and post triage, which has to be made in such situation. And the document expressively says, yes, it is correct to have a triage system. But what it also says is you should have clear triage guidelines before you come into that situation. What we have seen in some countries, unfortunately in many countries, is that they only started to think about triage systems when it was already on the plate, so to speak, you know, when the disaster situation had occurred. And that is something which we all should work on, to have clear triage guidelines before, what is acceptable during the triage and what is not acceptable. Coming back to the basic questions of medical ethics, what is not permissible is to have something non-individual, like for instance the age, as a triage criterion. That certainly is, as a standalone criterion, absolutely not acceptable. By the way, the Declaration of Geneva very clearly states that. But there have to be medical criteria which have to be fair to the person, but also fair to the community there, that have to be applied for this. And yes, of course, if you have a situation where you have a respirator and you know that you can't help the patient anymore with this respirator, but you have other patients who are waiting for it and can only survive, I think our guidelines clearly say that this is okay then to change the therapy and to continue with the other patient there. But the core problem here is, you have, as a medical community in your country, you have to set up those guidelines for the triage before you go into the disaster, and not only during the disaster. Then usually it doesn't really work, and doesn't work well. Thank you.
Dr. Gillen? Dr. Gillen?
Yes, indeed. I'd like to support what Ottmar's just said. These are horrible decisions to be making, and they only apply where there's simply not enough provision for everybody's needs to be met. But it's very important, I think, and I think the British Medical Association in its guidelines says so, that age on itself is not a criterion, nor is disability in itself. But the issue is how much benefit the individuals can get, and in a triage situation where there's overwhelming demand, for example, for respirators, how rapid the benefit can be. So, as it were, a matter of fairness between all the applicants for a very short resource. And in those circumstances, triage guidelines, however painful, which they certainly will be, are very important to set up in advance.
I guess I would feel comfortable adding that our guidelines in the United States have been changing during the crisis. So we clearly were not prepared. But one of the things that we've noted in our country is that certain people who are in certain ethnic groups or racial groups um, that tend to be discriminated against are also dying at greater proportions and actually getting COVID-19 in greater proportions than are their Caucasian counterparts. And so our guidelines have been changing to try to prevent this problem from happening. And the same thing with people who with disabilities, they've been shortening the period of time that you can look ahead when you're trying to decide what the benefits are going to be so that we can be more equitable in the way we're giving out respirators, for example. There is a question here. Well, it's actually a very long statement from Dr. Zarkowski. She said, I think it's a she, says that there are positions in medical ethics that the overwhelming majority of all well-informed and reasonably reasoning physicians agree with. But there are also issues where there are no negotiable positions and each party is able to cite the convincing ethical arguments of its position. In the latter cases, should the code arbitrarily indicate a correct position? Is it not better to admit that in the field we have not reached agreement at this stage of the development of medical ethics? Don't skip the problem, just write it down. There are positions in medical ethics that the overwhelming majority or all well-informed and reasonably reasoning physicians agree with. But there are also issues where there are no negotiable positions and each party is able to cite, it's kind of repeating it. So I guess, why don't you address that issue, Ramin?
I'm sorry, I have to apologize. I only got part of the question because of the noise I just had here. I had to mute myself. I might just ask, I think Professor Gillen just came online. Maybe he can respond to that. I didn't get the question.
Sure, but
Well,
let me just summarize the question, or maybe Dr. Gillen, why don't you summarize the question before you answer?
Well,
Dr. Gillen?
I think the question raises a hugely important issue, which is that of genuine moral dilemmas. And I think that we need to be very careful in the case of a genuine moral dilemma, where there are very good reasons, as the questioner indicates, for incompatible solutions. And I think that it's something that we must take huge account of, and particularly, I would say, in an international organization like the WMA, that there simply are different answers, and in my view, very often they are justifiable answers, even though they contradict each other. So I think trying to take account of moral dilemmas, as I think the questioner was suggesting, is a very important part of the work of the WMA. But of course, that's a controversial statement.
Great. And then this is our last question from Dr. Wuna Tung. Is it ethical for turning medical students into doctors ahead of schedule to join the health services to fight the pandemic? We've done that here in Massachusetts.
A very good question. And actually, we're discussing this here in Germany as well. You know, if we want to do it, in what way it should be done. And it is a good question. This is nothing we have discussed in the work group so far. And this is also nothing that we have discussed to be included in the ICME. I guess this is according to the policies of the national physician organization, national governments, I don't think there is an official policy on this yet. So as far as I know, I could only say my own opinion, but I guess that's not really asked for here right now. So unless someone, Urban, is there anything from official medical ethics point of view?
No, well, first of all, it's a question of the laws. What can you do if, as long as you are a student or not? But I think from the ethical point of view, it depends on the skills the student have and on the tasks he has to do. So if a student is at the end of the study, he has a lot of skills, he is well trained, and he has to support a physician, that might be a good idea. But of course, he cannot act as a physician and with the mandate of the physician and with the responsibility of a physician as long as he is not a physician.
Urban, before we leave, do you want to address the previous issue? Andy Gurman says you have an opinion on that. The previous issue on the difficulties of conflicting opinions of what is ethical.
Well, of course, we can address certain dilemmas in the code, but the idea of the code is to summarize what is all over the world acceptable on a certain level of generality, abstraction. Of course, confidentiality might be interpreted in some regions of the world differently from other regions, but confidentiality as an ethical principle is valid all over the world. And that's what we want to put together in this code. And of course, there are dilemmas, but the code doesn't address dilemmas. The code addresses the central, globally valid principles for members of this profession.
Okay, thank you so much. So I would like to thank Ramin for a wonderful, wonderful presentation. I'd like to thank Otmar, and also I want to thank all of the attendees. Thank you so very much. We'll keep you posted. And I'm sure that if anybody wants to contact Ramin directly, they can do so through the Secretariat and just let them know what your issues are. Any last words, Ramin?
Thank you, Joe. I would also like to thank you guys for inviting me, for giving this opportunity to present this topic. Also, thanks to the entire work group for those of you who joined today and those of you who actively participated in the discussion. Also, our ethics advisor, Urban Wiesing, and Dr. Kläuber. Also, as you said, if you have any further questions or input for our revision work, please send everything to the WMA Secretariat, and we'll make sure that this goes on our list for the work group to be discussed. Thank you so much.
And the email address for the Secretariat is secretariat@wma.net. So thank you all very much. We're going to end the meeting now.